chairpersons, for your kind words. Respected chairpersons, senior colleagues, and dear friends, a very good morning to all of you. I have been allotted with topic of optimizing patient care with learning from CVOTs. It will consist of overview of new classes of anti-diabetic drugs, rationale for CVOTs in management of diabetes, cardiovascular safety of new anti-diabetic drugs, particularly DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, mineralocorticoid receptor antagonist. Of course, it is not anti-diabetic, but have been found to improve the cardiac output in patients of diabetes, and then the implication of CVOTs for optimizing treatment. We all know that diabetes results from various pathogenic mechanisms, right from the decrease of the insulin secretion to the insulin resistance to the incretin defect. And till recently, we have been using three main classes of the drugs, biguanides, which used to decrease the hepatic glucose production, sulfonylurea group of the drug, which causes increase of the insulin secretion, and thiazolidine diones, which increases the insulin sensitivity. Later on, the concept of the incretin defect was identified, and it was found that there is a substantial impairment of around 40% of normal response of the incretin in patients who develop diabetes. And for this, a number of drugs or therapies were produced, and these were including injectable therapies, which were in the form of the GLP-1 receptor analogs, and the DPP-4 inhibitors, which are available in the oral tablets. This is a new class. These are the new classes of the drug, and as present, we have a number of the GLP-1 receptor analogs present with us for the treatment of diabetic patients. We will not go in much of detail of all these. Another new class of the drug, SGLT2 inhibitors, which inhibits SGLT2 receptors and reduces the glucose absorption, causes glucose-urea and protein calorie loss, also causes decrease of blood sugar and decrease of the weight also. Coming over to the rationale for CVO2s in the management of diabetes. We all physicians and the majority of the patients in 2007 were surprised when there was a study which suggested that rosiglitazone can increase the risk of myocardial infarction and death from cardiovascular causes. The drug which was being used for the treatment of the diabetes was found to cause cardiovascular damage, and in response to this, FDA released guidelines for the industry that for any new anti-diabetic drug to be launched, industry must demonstrate new therapies will not result in an unacceptable cardiovascular risk. And for this, they also prescribed a protocol, including MACE as well as the other indices, and said that these all have to be checked before they are marketed and patients take them, and so we can avoid cardiovascular diseases which can arise because of the drugs. And since then, a big number of trials have been done on the DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor analogs. Now, coming over to the various cardiovascular safety trials regarding these drugs, first we will see the DPP-4 inhibitors, saxagliptin through severtimi, alogliptin, sitagliptin, as well as the linagliptin have been studied, and it has been found that these drugs, as compared to the to the placebo, were found to be the safe as far as various primary endpoints for the cardiovascular diseases were concerned. They came out to be safe as far as cardiovascular outcome was concerned, and sitagliptin was found to be rather little beneficial for the cardiovascular outcomes. So these trials suggest that these DPP-4 inhibitors are cardiovascular safe as far as cardiovascular output is concerned, and there is no increased risk of cardiovascular disease with these drugs, and these drugs can be used in patients with the type 2 diabetes. In addition to this, these large trials have also explored other potentially beneficial effects of the drugs, as they do not cause hypoglycemia, they do not cause weight gain, and rather they have some positive effect on the albuminuria and progression of the nephropathy. Other group of the drug is SGLT2 inhibitors, empagliflozin, studied through EMPA-REG trial, and it was the results are very surprising, as the patients who were receiving empagliflozin as compared to the placebo showed not only non-inferior, but they were found to be superior. There was a beneficial effect on the primary cardiac output, There was a decrease of the cumulative incidence of primary outcome, cumulative indices of incidence of the death from the cardiovascular causes, and decrease in the hospitalization for the heart failure. So empagliflozin, which was studied to find out whether it is cardiac safe or not, it was found to be beneficial for the heart, and at the same time renal events and progression of the nephropathy was found to be reduced with the use of the empagliflozin. Canagliflozin in a similar way was studied in the CANVAS trial, again was found to be superior as compared to placebo as far as the various cardiac outputs, cardiovascular death, myocardial infarction and stroke was considered. It was found to be beneficial, particularly for the patients who, who, who were prone for the development of heart failure. There was markedly reduced incidence of the hospitalization for the heart failure. This drug again was found to be beneficial for the progression of the nephropathy also. Composite of 40% reduction in EGFR and stage renal disease or renal death were found to be reduced with this drug. Credence trials showed that the primary outcome were related to the renal progression of in diabetes, and it was again found to be much beneficial in patients with the diabetes, with kidney disease or diabetic nephropathy. The progression of the renal disease was found to be quite decreased, including development of the end-stage kidney disease or the replacement therapy for the dialysis or death because of the renal cause. As well as the cardiovascular outcome was found to be beneficial in these patients. Credence trial again showed that these patients were better, the patients were receiving canagliflozin were having much better outcome as far as the development of various cardiac problem was concerned and the renal problem was concerned. Dapagliflozin, like that of the was also studied through DAPA-F trial, and we can see that it was found to be again better for as compared to the placebo for the development of various cardiovascular and renal outcomes. Ertugliflozin was also studied and which was found to be cardiac safe, and it was going to it also showed that there was much decreased death of the because of the cardiovascular causes, or the hospitalization from heart failure was also reduced. Renal outcome was also found to be beneficial, and there was a decrease of the nephropathy by 19%. So to summarize, with the SGLT2 inhibitors in the management of diabetes, it was found that these drugs were found to have no increased risk of the cardiovascular disease. They were safe, and at the same time, they were found to have beneficial effect on the MACE, heart failure, albuminuria, and as well as the progression of the nephropathy. And at the same time, they also were found to have significant weight loss and there was less risk of hypoglycemia. SGLT2 inhibitors have emerged as potentially beneficial group of the drugs as far as prevention of cardiovascular disease and renal failure is concerned. Other group of the drug was GLP-1 receptor agonist, lixisenatide, studied through ELIXIR trial, was found to be non-inferior to the placebo. And the things, there was an eye-opening trial, LEADER trial, where liraglutide was studied, and it was found as compared to the placebo, the cardiac output was found to be much beneficial. It was superior, not only non-inferior, and various 3-point MACE and cardiac output were found to be improved with the use of the liraglutide in patients of the diabetes. So it suggests, and this drug was also found to have beneficial effect on the various indices of the nephropathy, macroalbuminuria, doubling of the serum creatinine, and its renal disease, and death because of the renal cause. So this drug liraglutide was found to have beneficial, not only non-inferior effects on the cardiovascular and the renal outcomes. Semaglutide, studied through SUSTAIN trial, had similar kind of the effects, decrease in the cardiac outcomes, better, it was found to be beneficial, it was superior as compared to the placebo, development of myocardial infarction or non-fatal stroke. Oral semaglutide, studied through Pioneer trial, again was found to be much better as compared to the placebo. It also was found to have caused significant reduction in the hemoglobin A1C and the decrease in the weight. Dulaglutide, studied again through REWIND trial, also revealed that there was a positive outcome as far as the cardiovascular complications were developed. Rewind trial also showed there was a beneficial effect on the HbA1c, weight, blood pressure, and heart rate. The Rewind trial also showed that there was a positive impact on the development of the nephropathy in these patients of the diabetes. To summarize with the various trials, CVOT trials with the GLP-1 receptor agonist suggest that there was no increase for cardiovascular disease. They were safe, and at the same time, they were also showing that there was a positive effect on the cardiac output as well as the renal output. And GLP-1 receptor analog have come out as a promising group of drugs for prevention of cardiovascular disease or renal failure. Another group of the drug, that is mineralocorticoid receptor antagonist, that is again non-diabetic but have been found to have beneficial effect on the renal and cardiac outcomes in these patients with type 2 diabetes. And this is a non-steroidal renal and mineralocorticoid antagonist was found to have improvement in the diabetic nephropathy as well as the cardiac outcome in patients of the type 2 diabetes. Now coming over to what are the implications of these CVOTs for optimizing treatment? How should we make consideration for selecting therapy for patients of type 2 diabetes? The drug should be potent enough to result in HbA1c reduction. Beneficial effect on the body weight or BMI should be there. There should be no hypoglycemia, particularly in elderly patients or the patients who have hypoglycemia unawareness. And at the same time, because we know that the major cause of morbidity and mortality is cardiovascular diseases and renal failure, so it should not have any bad effect on the cardiovascular outcomes, and rather they should be benefit for it. So these CVOT trials have helped us in understanding various advantages of these newer drugs for optimizing therapy and help us treating diabetic patients more judiciously to reduce morbidity and mortality in diabetic patients. ADA also recommends that after metformin, SGLT2 inhibitors and GLP-1 receptor agonists can be used as a second-line drug. And they also recommend that in patients with long-standing suboptimally controlled type 2 diabetes and established atherosclerotic cardiovascular disease, empagliflozin or liraglutide should be considered, as they have been shown to reduce cardiovascular and all-cause mortality when added to standard care. Various cardiology societies, American College of Cardiology, American Heart Association, and ESC suggest that these drugs, SGLT2 inhibitors or GLP-1 receptor agonists, have protective effect as far as cardiovascular risk factors are concerned, and they can be used or added for primary prevention of cardiovascular disease, and they have cardiovascular benefits. And SGLT2 inhibitors and GLP-1 receptor agonists can be used in patients with cardiovascular disease or those who have high cardiovascular risk. European Society of Cardiology suggests that type 2 diabetes drug-naive patient, if there is any evidence of atherosclerotic cardiovascular disease or cardiovascular risk, these patients can be started right from beginning with the SGLT2 inhibitors or GLP-1 receptor analogs, and those who do not have these risk factors can be started with the metformin. So these drugs, after these CVOTs, are being considered as the first-line drug for selected patients also. Kidney disease improving global outcome guidelines suggest that in patients who have type 2 diabetes with diabetes kidney disease, SGLT2 inhibitors are the first-line therapies because there is a positive effect on these nephropathy, and renal outcome is improved with the use of the SGLT2 inhibitors. SGLT2 inhibitors have also been found to cause various other beneficial effects like improvement in HbA1c, weight loss, and decrease of the blood pressure. They particularly causes decrease of heart failure. So now coming over to how CVOTs help us to optimize therapy in type 2 diabetic patients with comorbidities. These all trials suggest that those patients who have ASCVD can be treated with the GLP-1 receptor agonist and SGLT2 receptor inhibitors, as both of these drugs have come out with the positive outcomes as far as cardiovascular disease is concerned. The patients who have tendency to develop heart failure, SGLT2 inhibitors are the drug of choice for these patients, and followed by the GLP-1 receptor agonist. Patients who have renal disease, again, SGLT2 inhibitors have several advantages. We can retard the progression of nephropathy, and GLP-1 receptor agonists like the liraglutide or semaglutide have also been found to be useful in these patients. In patients who have obesity, GLP-1 receptor agonists, they have marked effect on the weight loss. SGLT2 inhibitors or metformin can be used. Patients with the cerebrovascular disease, GLP-1 receptor analogs, and patients who have risk for the hypoglycemia, DPP-4 inhibitors, GLP-1 receptor analogs, or SGLT2 inhibitors can be used. To summarize, we can say that various CVOT trials done for these DPP-4 inhibitors, GLP-1 receptor analogs, or SGLT inhibitor have shown that these are safe as far as cardiovascular events is concerned. A number of trials for the GLP-1 as well as the SGLT2 inhibitors have shown they are safe as far as the cardiovascular events as well as the development of nephropathy is concerned. And we can optimize therapy according to need. GLP-1 receptor analogs and SGLT2 inhibitors have come as paradigm shifting therapies, and SGLT2 inhibitor and GLP-1 receptor analogs are associated with the weight reduction. There is no risk of hypoglycemia, cardiovascular safety, and renal benefits are there. To conclude with, we can say that CVOTs have made us understand various advantages of these newer drugs. We can optimize therapy according to the comorbidity. These CVOTs help us treating diabetic patients more judiciously to reduce morbidity and mortality. The last, I will like to thank you all and like to invite you for the EpiCon in the month of the March from 10 to 13 in Jaipur.